Good morning. What? Good morning. So I've been asked to talk about the basics of Parkinson's disease. So this is for people who really are wondering if they've been diagnosed or if they've been recently diagnosed. You're going to hear a lot more advanced information as we go through the day from other speakers. So we're going to talk about what Parkinson's is, who gets Parkinson's, why do people get Parkinson's disease, is there some way we can stop or reverse Parkinson's, and what is the main treatment for Parkinson's? So as many people know, probably if you've had Parkinson's for a while, you've seen this slide or you've seen similar slides that James Parkinson really described this syndrome or disease back in 1817. But we've known a lot about this disease probably for longer than that from other parts of the world, Indian medicine and things like that. So it's not really a new disease. It's been around as long as people have. But once it was described, then we could start looking at the things that are the features of it. So the main things that we see with Parkinson's when it's first diagnosed are a resting tremor in one hand, problems with balance and reflexes. Muscles can be very rigid, and if you try to move, can feel very stiff. And another thing we notice is slow movement. So you can walk slowly, talk slowly, move slowly. So this is just a little picture of a patient or potential patient with this stooped, bent-over posture, and the arms are bent, and he has decreased facial expression, and there's a little bit of movement in one hand, so he's got a tremor. And this is a picture of Michael J. Fox. So Michael J. Fox, as you know, has Parkinson's, and he's been a wonderful advocate for Parkinson's all around the world. So he's got decreased facial expression here. His hands are in a posture that we call tenting, which often happens due to the stiffness. People with Parkinson's also get freezing of gait, where they get stuck in the middle of walking. Falling is another common feature. Problems with eye movements, looking up or down, can be an issue as well. And then very small handwriting. So down on the bottom here, you see how the handwriting starts out large and then gets smaller as it goes by. And that's something we call progressive micrographia. It's very characteristic of Parkinson's. So these are what we call Archimedes spirals. So on the left, you see a normal spiral that has been drawn by the doctor or the examiner. In Parkinson's disease, this second spiral the spirals are very tight and small, kind of like the handwriting. And it looks very different from other types of tremors. These are samples taken off of checks and other things that people have signed over the years with Parkinson's. So in each of these three examples, you see that as the years go by, the handwriting goes from large to smaller to smaller to smaller. So other than the things that you can see on the outside, we also have what we call non-motor symptoms and signs of Parkinson's. And these tend to be things like depression, which is very common, apathy, which is also very common, cognitive impairment, or maybe the beginnings of dementia. Hallucinations can happen very often. Memory loss is another feature, but not as much as we would normally see in something like Alzheimer's disease. Sleep problems, as you'll hear on the next talk, are very common as well and can be addressed. Inability to smell properly is probably one of the things that happens first. Also, the gastrointestinal tract becomes involved pretty early on as well. People get constipation, and that constipation can precede the actual diagnosis by 5 or 10 years easily. Problems with heart rate, low blood pressure when you stand up, drooling, unexplained sweating episodes, and sexual dysfunction are also common as well. People get aching muscles and joints, which you wouldn't normally think would happen with Parkinson's if you look at why it happens, but it does. It's very common. So another thing we get asked about often are, what type of Parkinson's do I actually have? And there are different subtypes of Parkinson's that we know of. So one of them is when people have no tremor at all. We call that atypical Parkinson's disease. About 5% of people, or maybe more, have no tremor at all when they first get Parkinson's. Another 5% or more have this flapping tremor variety where on both sides they have very vigorous tremors that really don't respond very well to medication, and so they often get misdiagnosed as having something called essential tremor, and vice versa. Some people have a very stiff presentation where they really can't move or walk, and they have stiff arms and legs, and that's called akinetic rigid syndrome. And then some people get this postural instability form where their legs won't move at all, and they really can't walk very well, but the upper body is not affected as much. So Parkinson's is kind of variable. So not every single person has the same picture with Parkinson's. As you know, if you have any friends that have Parkinson's or you've been to any of these support groups, you can have 25 people in a room and they all have different forms of Parkinson's. They look different, they take different medications. So Parkinson's is really not just one disease. So sometimes people have other things on top of their Parkinson's that can look different as well. If you have problems with urinary incontinence and passing out, then you might have a disease called MSA, or multiple systems atrophy. If you can't look up or down, or your eye movements are restricted and you tend to fall backwards, you might have this disease called progressive supranuclear palsy, PSP for short. And the third one is corticobasal degeneration. So that's a very rare disease where people have difficulty using one hand and their language becomes affected. Something that's a lot more common is called dementia with Lewy bodies, which can often be mistaken for Parkinson's. In fact, in reality, it's an overlap syndrome. So people can have what we think of as classic Parkinson's disease and have some features of Lewy body and vice versa. So sometimes it's kind of academic because the diagnosis can be hard to make. The thing that's mainly the feature of Lewy bodies is that people tend to get hallucinations, and those can be 60 or 70% of people within about a year of getting Parkinson's symptoms. So with Parkinson's, you can get hallucinations, but that usually takes about 5, 10, or 15 years. That's different from Lewy body. Okay, so this slide came out a little jumbled, which actually kind of makes sense because in the middle it says Parkinsonism, or it's supposed to say Parkinsonism. So unfortunately, you can't really read it, but the point is that there are many, many things that look just like Parkinson's disease. You can have psychiatric problems with depression. You can take psychiatric medications that can cause you to look like Parkinson's. You can have head injuries. You can have strokes. So there's a lot of things that are not really Parkinson's disease per se. But that's why you need to see a movement disorders specialist or a neurologist who knows about Parkinson's and those syndromes, because the treatment is important. Okay, so in Parkinson's disease, you see this nice little picture here. I'm going to see if this pointer works. Okay, so down in the middle of the brain here, this is called the substantia nigra. And this part of the brain right here has these neurons that's making dopamine. And so dopamine is the main thing that is missing in people with Parkinson's. So what happens in Parkinson's is the brain cells that are making that dopamine die. And why does that happen? Well, these little clumps of protein build up. And when those clumps of protein build up, they start to interfere with the function of the nerve cells. So the nerve cells themselves can no longer function and make dopamine, and eventually those protein clumps get so built up that the nerve cells die. This is another picture showing these little fibers on the left. Those are fibrils of alpha-synuclein. Alpha-synuclein is the bad protein that builds up in Parkinson's. So that's the one that we know eventually causes clumps and these blobs in the middle of the cell. Those blobs in the middle of the cell were called Lewy bodies. So even people with Parkinson's have Lewy body blobs in the cells, but that doesn't mean they have Lewy body dementia. So you're going to hear those terms interchangeably, but a Lewy body, in this instance, is actually just a blob in the middle of the cell. And so this is actually a picture of what a Lewy body looks like under a microscope. So it really does form a big glob of protein, almost like an egg. And when those globs of protein build up far enough, they interfere with the function of the cell, and the cells die. So one thing we know that we didn't really used to know in the beginning was that the entire brain is affected by Parkinson's. Yes, the part in the middle there, the substantia nigra, which is right here in the very base of the brain, so that does get affected, and we can see it on basic brain slides. I'll show you in a minute. But we know that it goes all over the brain. Because we know now it goes all over the brain, we've been able to look at different parts of the brain as to where it starts and where it ends up. So this slide shows on the upper left, the blue area is the good area where you don't have any Parkinson's symptoms or signs, and on the right, where it's dark red, is where the Parkinson's shows up the most and lasts the longest. So I'll show you in a minute what that means. So there's a researcher in his group in Germany named Dr. Brock, Heiko Brock, and he discovered, or he has hypothesized, and it seems to be working out, that Parkinson's goes into the brainstem and maybe even to the front of the brain and then progresses very slowly over time into the entire brain. So on the left, you see this little pinkish or dark red areas that are affected by Parkinson's, and that's early in the disease. In the middle slide, you see that more parts are turning red, and finally in that last part on the right, you see that the whole brain is eventually affected. There's a researcher and wonderful clinician out in San Francisco, Dr. Langston, who made this slide. What he is pointing out with this is kind of what I'm trying to show you with these slides of the progression of the disease, that Parkinson's is kind of like an iceberg. So at the top, you see people that have a tremor, they have problems with walking and slowness, but as those other parts of the brain become affected that are listed here, and there's gonna be a test later on these names, by the way, okay? But as those parts become affected, we see that those things result in others, non-motor symptoms that we talked about earlier, psychiatric problems, gastrointestinal problems, heart rate issues, and eventually that becomes more of an issue than the tremor. So who gets Parkinson's? Well, if we look at what happens, at least in the United States so far, we know over 1 million people have been diagnosed with Parkinson's here in the US. Maybe by 2025 or 2030, we think it might double because of just basic demographics with aging baby boomer population. So there's probably going to be 2 million people over age 50 by 2030 that have Parkinson's. If we look around the world, it's again 1.5 to maybe 2% of the population, but in the US, it seems to be diagnosed more frequently. The average age for diagnosis is around 62 years old, and it affects men more than women. So about 2 men for every 1 woman that's diagnosed with Parkinson's. Lifespan used to be shortened, but with proper medication and exercise, lifespan is pretty much normal nowadays. Of course, disability does build up over time, but again, lifespan itself seems to be more normalized. In this area, just in Sarasota, Manatee, we've calculated that there's probably 5,000 people that have Parkinson's. It's a huge need. There's also a big economic impact because it probably doubles the amount of money that you have to spend on healthcare once you get diagnosed. So what else happens? Well, we know that about 20 to 60% of people will wind up getting some form of dementia or cognitive dysfunction. People with Parkinson's are about 4 times more likely to have a car accident. That doesn't mean you shouldn't drive. It just means you should be aware of that. If you go down to the Department of Motor Vehicles and they see a tremor and they say, "Do you have Parkinson's?" and you say yes, then they'll require a release from your doctor to say that it's okay for you to drive. Depression is very common, probably for chemical reasons due to not making dopamine and other neurotransmitters, but also emotional factors, things like that. But also spouses have about the same amount of depression as people with Parkinson's because it's a tough process to be caregiving for someone that has Parkinson's. You love them dearly, but at the same time, it's a day-to-day, and as years progress, things get tougher. So that needs to be addressed. I want to encourage caregivers to make sure that their thoughts are clear to the doctor and also to their own doctor as to how they're feeling with this. So again, men are more likely to get Parkinson's. As people get older, they tend to get Parkinson's. Agent Orange exposure. If you were in the military in the 60s, you were in Vietnam, anything like that, any Agent Orange exposure, you can be covered for that through the Veterans Administration, so you should look into that. Pesticides, herbicides, fungicides. So we know that people who live around farming communities tend to get it more. Also people in dry cleaning industry, and then sometimes people with Jewish heritage or Basque heritage. There's a certain gene that can be associated with it. So one of the researchers up in Chicago has asked whether or not Parkinson's might be a normal consequence of growing old. So we know that as you get older, you're more likely to get Alzheimer's. And we can also show that as you get older, you're more likely to get Parkinson's. So this is a slide just showing that the incidence of Parkinson's around age 35 is very, very low. And as time goes by, it goes up. So that looks like an age-related disease. This is looking at dementias also. So again, Alzheimer's, dementia increasing dramatically as you get older. There is some increase in dementia from Parkinson's also as we get older. And finally, this is a similar sort of a slide, again, from another study showing that Parkinson's is more likely as you get older, especially in men. Seems that there's maybe a drop-off in women as they get older. Okay, so once again, just to review, we know that Parkinson's is caused by loss of those little cells down deep in the brain. By the time you're diagnosed with Parkinson's, you've probably lost 30% of the cells. But on top of that, another 30% of the cells or so are probably sick and not functioning properly. So maybe you've lost 60% of your ability to produce dopamine. So this is a slide looking at two different patients, and I've seen this on teaching neuroanatomy to medical students. We cut up the brains, so we have brains that were donated to us, and we cut up the brains. And in a normal person here above, we always see this little darkly stained area where these cells are making dopamine, and people who have Parkinson's, it's whited out. They just are not making any dopamine. And again, on the right, you see that blob there in the middle of the cell. That's the Lewy body. Okay, so if we look at what happens with people with Parkinson's over time, on the left, you see the severity of the symptoms, basically. And on the right, you see this x-axis is time. So this red line, as you see it's going down, is people's dopamine neurons dying off over time. So that takes a while for that to actually show up as a syndrome that your doctor can diagnose. By the time your doctor diagnoses you, we think you've lost 30% of those cells. And again, are probably only making about 40% of the normal amount of dopamine you should have. And then as time goes by, both the motor symptoms and those non-motor symptoms that I mentioned increase. So again, why does this happen to people? We don't know. There are genes that are associated with it. Maybe 5, 8, 10% can be associated with genes. There's also some sort of gene-environment interaction that's probably predisposing people to getting Parkinson's as well. But also we know there are some personal habits that may increase your risk of having Parkinson's. And also health factors. If you have good cardiovascular health, you're less likely to get Parkinson's. So again, there's some genes. We're not going to go into this too much, but again, there's probably 3 or 4 genes that are more common, including the one that I mentioned, LRRK2, which is in Jewish communities. Okay, so can we stop or reverse Parkinson's? I get asked this fairly frequently. So right now, we don't know if there's any drug or supplement or anything that will stop Parkinson's or even reverse it or slow it down. We do have pretty good evidence that exercise seems to slow down the progress of Parkinson's. So I'd like to see a show of hands. Who here is on board with exercise on a regular basis? Great. I love it. Okay. So if you did come to my talk about 4 weeks ago, we had a symposium out at Rand Boulevard where I talked for about an hour about the benefits of Parkinson's and exercise. So we know there are very good studies that show that people with Parkinson's who exercise have better cognitive skills, they have better memory, they have less severity on terms of these motor scores that we give people. They're more confident, they have less depression, they're more likely to go do the things they like to do. They're more likely to go on a trip. They're more likely to go golfing with their buddies, you know. So exercise is very, very important. And I like to say, and I think a lot of other specialists in this disease like to say that it's as important as any medication we can give you. So remember, exercise is as important as any medication we can give you for Parkinson's. So that goes along with a good cardiovascular health. So we've studied things like people who are in spinning classes and vigorous exercise classes with Parkinson's. They definitely do better. And I have seen that in my practice as well. I have seen the people who are not sedentary, the people who are exercisers, they do the best in the long run. So another one of my little sayings is I like to say, being sedentary is like taking poison for Parkinson's, okay? You cannot be sedentary with this disease. Okay, so what are the treatments? So we're going to talk about medication, exercise, we talked about, some rehabilitation, but also getting information like coming to NeuroChallenge events and going online, other national resources. That's actually a treatment because in my mind, it helps you to kind of prepare for what might be coming down the pike. And it seems to sort of delay anxiety. Anxiety can be a big problem with Parkinson's, especially if you don't know, when am I going to get worse? How bad off am I? That sort of information, I think, helps in the long run because it makes you less anxious and it helps you get prepared. And then support groups. We have wonderful patient support groups. We have wonderful caregiver support groups. And you can take advantage of those, not only in Neuro Challenge Foundation, but also with a number of organizations around this county, around the area. So again, going back to this one slide, we're going to look at the lack of dopamine being produced in that bottom slide there, or that slide with the bottom brainstem. So there's lots of ways we can replace dopamine. We can also give you what we call fake dopamine or synthetic dopamine, which is a dopamine agonist. We can block the breakdown of dopamine in your brain. We can help dopamine get released more. We can reprogram the brain, sort of, with deep brain stimulation. And then we can treat the other symptoms that are involved. So those non-motor symptoms are things that are addressed with other medications and other means, including dementia with Alzheimer's type drugs, hallucinations with some antipsychotics, constipation, drooling, dyskinesia, which is the wiggling movements that some people get, we can treat that, depression, sleeping problems, and again, melanoma is actually more common in people with Parkinson's, so you should just be aware that if you have Parkinson's, you probably should get a skin exam at least once a year by your dermatologist. Okay, so looking at what happens with people with Parkinson's, what we want is to get dopamine into the brain. So this slide shows Sinemet, which we'll go over in a minute, which is Levodopa, getting into the brain, going through a process to be converted into dopamine, and then eventually it's going to slide over to the cell on the end there. So those little blue pegs that are sticking up, that's another cell that's waiting to receive dopamine. That's what we want to stimulate with this dopamine. Okay, and so there's other ways to get dopamine in, which we'll talk about. So dopamine, at least for now, is probably still the most effective drug that we have, or Levodopa, in the form of Sinemet. We have a lot of other drugs that are also very useful and very helpful. When people first get Parkinson's, on this left panel here, you see that there's this nice big green window. You give them Levodopa, and it's wonderful. They think that the doctor is a genius, even though the doctor didn't create or produce the medication. But people get better, 60 to 80% improvement basically in symptoms. Some people respond very well, some people don't. But on average, very early in the disease, any dose of medication will work for relieving the motor symptoms. As time goes by, in this middle panel, that little therapeutic green window gets tighter. And eventually, as years go by, it gets hard to reach in that nice little green area, and you start to overshoot by accident just because the medications get into your system. And when you overshoot, that's when people tend to develop this thing we call dyskinesia, which is this writhing, dancing movement. So we want to shoot for that green area as much as possible. And here's another little slide that just shows that getting you into that good area with good on time and less off time can be difficult. And the little gray line shows that the person's not stimulated enough, and then the black line shows they may be a little overstimulated. Okay, so in terms of medication, carbidopa-levodopa has actually been approved for, I think, 45 years, and that's also called Sinemet. So Sinemet is a French term which means no vomiting, and the reason is because you have levodopa, which gets converted into carbidopa, and then we also have levodopa, which gets converted into dopamine, and carbidopa, which keeps you from getting nauseated. So Sinemet means no vomiting. That's why that extra drug is in there. There's different ways to get this into your system, but basically most people wind up taking it 3 or 4 times a day. You can actually take extra carbidopa if you have nausea with Sinemet, which some people continue to have despite the carbidopa. You can take extra carbidopa in the form of Lodocin. There's also a drug called Sinemet CR, which some people find useful to take at bedtime. It's a controlled release form. Some people don't really notice that much of an additional benefit. So dyskinesia, which we talked about a minute ago, is something that can develop after 5 to 8 years on this medication. All right, so we're talking about giving you levodopa, getting it converted into dopamine, and then it's going to stimulate those little blue receptors on the cell down the line. Okay, so there's different forms of getting it into you. So this top form here is Sinemet 25-100 pill, carbidopa-levodopa. That's an immediate release pill that I would say 90% of people who take Sinemet take. There's also an oral dissolving tablet if you can't swallow well. There's extended release pills, there's controlled release, there's a 25-250 pill, which is a bigger dose. There's Rytari extended release capsules. There's a Levodopa inhaler, which you can use if you're having an off time. And there's also an intestinal gel or Duopa pump, which can be used. And that gets pumped directly into your small intestine. So there's also drugs called dopamine agonists. So these act very similar to levodopa or dopamine, but they're about 100 times more powerful. They last a little bit longer. They have a longer half-life in your system. They also are dosed 3 to 4 times a day unless you're on this rotigotine patch, which is once a day. They may delay getting this dyskinesias. So there's kind of a debate, which has been ongoing for many, many years in our Parkinson's community about which drug to use. Do you use Sinemet and get dyskinesia maybe a year earlier, or do you use these dopamine agonists and get it a little bit later? Well, Sinemet may give you more quality of life, so Sinemet may give you more relief from your symptoms and have a little bit less side effects. So it's kind of up to the doctor and the patients to discuss which one might be best for them. And these come in generic forms now as well. So again, looking at this slide here, so going to that one spot where we want to stimulate those blue receptors. So coming in from the side here, that's the dopamine agonist that comes in and stimulates those receptors. So that's the pramipexole, ropinirole, and rotigotine. Okay, so another way to do this is to keep the levodopa or dopamine in your system longer. So we can give you enzyme inhibitors that will block the breakdown of dopamine in your system. So in the left side of the slide here, we can actually try to get the levodopa into your system, and then carbidopa is actually also helping to keep you from having that nausea. And then after the dopamine is produced, it either gets taken back up into the cell where it has this blue thing that says DA going through this yellow tube here, or it slides out of the synapse and gets broken down by these two different enzymes. And so we can block those enzymes with enzyme inhibitors. There's a new drug that just came out. It's called Norians or estradifylline, however you want to say that. Just got approved by the FDA. And that drug helps give you less off time. And it works by a totally different mechanism than this whole dopamine system, or at least direct dopamine stimulation we're talking about. Interestingly, this drug is listed as having no drug interactions. So I have a few patients that have been started on this. I don't think we've had enough feedback right now for me personally to tell you how it's working, but so far the studies look good, and the FDA has approved it, and I think it's going to be an important drug. Okay, so beyond drugs, what do we do? Well, we know that there are rehab modalities that are very helpful. So has everybody here heard of LSVT Big? So raise your hand if you've not heard of LSVT Big. Wow, okay, so LSVT Big stands for Lee Silverman Voice Training and Big Therapy. So Lee Silverman and the group started this voice training therapy for Parkinson's, so it would make you talk louder, and speak with better diction. But then they discovered that maybe they could also extend that to the physical part of this. And so we have exercises through a rehab therapist that are very specific to big therapy, to Parkinson's. So this was actually created in 1987 with Dr. Lorraine Ramig. And many, many studies have gone on that have supported the fact that big therapy does help people. It helps reduce your risk of falls. It helps to improve your walking speed, reaching for things. A nice study was done in 2018 with 114 patients, showed a 40 to 50% improvement in these different little scores that we use to judge how you're doing with your walking. And that's getting up out of a chair quickly, also motor scores and cognitive scores. So all those things improve when you take Lee Silverman Voice Training Big Therapy. So this is just a small smattering of what the therapist trains you to do in big training. It's pretty intensive. It's about 4 times a week for 4 weeks, but it absolutely matters. If you keep up with the exercises at home, which you have to do, then it will help you reduce your risk of falls, help your walking. So another thing I like to say is you have to do the exercises, okay? So after the therapist is done with you, they've done their wonderful job, they go home, you have to keep up with it, and it does matter. So we've done follow-up studies 6 months, a year down the line, and we know that people who keep up with the exercises, they continue to do well. So they also have group therapy classes that follow up on the individual therapist, and We have some of those that are around as well, and those are helpful, and people enjoy them. And this is, you can also get a DVD that will then torture you because it'll force you to do these things at home as well, okay? So there's actually 2 of them. They're very useful. And then, so the loud therapy was actually what was created first. And loud helps you to speak louder. People with Parkinson's have a very soft voice, and it can be very hard to hear them as they get soft and they get trailing off. So this teaches you how to project your voice. Part of the thing that it works on is your posture, so that you learn how to project your voice by having a better head posture, and also taking a deeper breath and thinking about actually almost yelling. So again, this has been supported by multiple studies that show it can double the power of your spoken voice. And then after you're done with it, of course, there is a DVD that you can buy online. It's really not expensive, and it's very helpful. I think the voice therapy, in my experience, has been the hardest for people to keep up with because they're kind of embarrassed by singing and yelling at home. So I often encourage them to do it in the shower or when they're driving down this road. You know, maybe if someone's not driving so well in traffic, you could yell at them. But if you try to speak louder and you use these techniques, it absolutely does help. Okay, I've been given the red warning here. I'm running out of time. So thank you very much for your attention and for coming here this morning. You're going to have a wonderful bunch of speakers, panel, that you're going to learn a lot of more, probably detailed information about things that I've just covered briefly. Okay? Thank you very much.